like to welcome Dr. KVS Harikumar for his next talk. Dr. KVS Harikumar served in the Indian Army for more than 24 years and currently is working as a consultant at in Hyderabad. He also works as editor-in-chief for International Medical Journal and editorial board member for six other journals. He published more than 200 research papers, and he was awarded with various prestigious medals across the country. And he also had Best Research Award from RSSDI and UPDA. And without further delay, I would like to go ahead with this talk.
Good afternoon, everybody. Thanks to Team Idea and Dr. Shyam for inviting me. And before there's some slight change, so as chairperson has rightly said, before I start, let me just ask simple question. How many of you have used insulin in your clinical practice? Just raise your hands. Okay, not many. So then my job is more easier, I should say, because should not be having more questions. We are talking about generation 2 basal insulin, addressing some of the aspects of clinical management, what we are going to make a difference in the lives as what a normal drug would otherwise be unable to do. I'll cover the topic under the following headings, 15 minutes or so. Few concepts about the time in range and glycemic variability. What are the global recommendations and how do we address with the current generation basal insulins? And obviously, I'll conclude soon. This is the evolution of basal insulin. Any insulin requirement in a body is just divided into two components, the basal and a prandial. The basal giving you a 50% and a prandial another 50% of it. Even in your fasting state, there is some role of insulin in the body. It is not only to decrease the glucose, insulin is there in the body. So that is the basic understanding that you have a insulin production throughout the day, irrespective of your meals. Obviously, the moment you consume meal, it goes up to cover up for that extra glucose load. Right from insulin, we are in the centenary year of insulin, and after about 2-3 decades of insulin, there was some component to suggest that now we should have a better control of the fasting glucose. So there, how to prolong the action led to development of NPH insulin, which progressed, had some issues, and then we had last 3 decades, we had the first generation basal insulins, the glargine and detimer, and last 3-4 years now we have the second generation insulins, which are the degludex and the glargine 300 units. Okay. Now, when we look at the management of glucose, there are 3 different components initially, that is the fasting, postprandial, and later on now A1C is well established that A1C also should be equally good control. But further extension to it have come to these additional parameters what we look at. One is glycemic variability, the second is the hypoglycemia, all day or nocturnal hypoglycemia. So you should be able to control the glucose without giving the patient any hypos and without causing wide fluctuations in the glucose. So that is what is the basic aim. And that is what is that glycemic variability meaning. Variability basically means the fluctuation, the peaks and troughs in a particular day, how they are variable, how much of it is varying. So the moment there is more peaks and more troughs, the trough will give you that risk of hypos and maybe a nocturnal hypos. The peaks will lead to endothelial damage and lead to a more cardiovascular dysfunction. So you should have as narrow range as possible. And this is important because A1C as a number does not capture your variability. If by just looking at 7% may not give you that clue as that your A1C is not reflecting how widely the glucose is fluctuating in the patient. So that is important to understand that you should be you may be having an A1C of 7% with a high variable and your outcomes are still bad. So that is where actually when you look at why more number of diabetics are still having vascular events, some of these things are coming into place and then you are looking at how to address them in the clinical practice. So if you look at now the usage of what is the continuous glucose monitoring systems have come established well in the clinical practice. So that is where the concept has come of the time in range. Basically, what it means is how much of the time in a day you have spent in an ideal glucose environment. So if you have say catered say 70 to 180 milligrams per deciliter as an optimum, be it fasting or be it postprandial meals, how much of the entire day you have spent in that range is what basically the time in range. And across the board in the last decade, the time in range has been established and now is part and parcel of all the guidelines what have come in the management of diabetes. And generally 70% of the time you should be in the range, and with a minimum only 5% of hypos and maybe above time below range and above range as minimum as possible. So if you look at what is the target what you decide, it is at least 17 hours per day, that is more than 70% you should be spending time in a range of 70 to 180 milligrams per deciliter. And as akin to A1C, your time in range also is associated with all complications of diabetes. It is an indirect marker, you can say, because somewhat A1C also reflects that. But beyond A1C, your time in range as an independent marker also is associated with retinopathy, nephropathy, and neuropathy. So, if you are able to have some interventions which will keep you maximum within the range, possibly all these complications are reduced. And what are the guidelines which say that how much of time you should be spending in the time in range? If you look at this chart, I'm sure most of you cannot see this, but nevertheless I will tell you 70 to 180 is the range, that is 70% of the time you should be spending that, and below that, that is time below range, only 5%, and time above range is about 20 to 25%. So that is important to understand that majority of the time you should be spending between 70 to 180 milligrams per deciliter. And ADA has now in most of the standards of care for last 3 years, it has been part and parcel of the ADA standards of medical care for diabetes, that you should be having this much of time in range. Now when you look at, you have a parameter which is important in the clinical practice, which will give you a better outcomes. Are we having any drugs which will help us in reaching this objective of keeping the patients in their range? So what are the what are the drugs which are available? We'll talk about the basal insulins. The basal insulin, as I said, will give you a 24-hour coverage. That is why it is known as a basal coverage, unlike the prandial. And it reduces the glycemic variability by controlling the peaks and troughs. And you have, as I said, the first generation ones were the first generation were the glargine, and pre-basal first generation, you have the NPH, which had more variability. And currently available basal insulins, if you look at the NPH, most of the times we are limiting our use of NPH because of its high variability, lack of action to a predominantly 24 hours. So glargine is the benchmark as far as the basal insulins are concerned, the first generation one, which has almost a duration of action of about 20 to 22 hours. And Detimer to a certain extent almost falls there. And you have the good second generation ones, the concentrated glargine and degludec. And why it is actually more beneficial, the second generation basal insulin, is because the glargine 300 is basically a 300 units compact in a per ml strength. So what it means is, earlier you had a glargine of 100 unit per ml, now you have 300 units in the same ml volume. So what happens is the microprecipitate is further narrowed size and it diffuses more slowly in the system, and because of the reduction in the volume, the compliance and the injection, all things will become more smoother. So it is just a microprecipitate and further concentrated insulin of the glargine. The degludec has a different mechanism of prolonging its action. It forms a long chain of multi-dihexamers, and the zinc and phenol gradually dissociates, and then that keeps releasing the insulin over a regular times. If you look at comparison between first generation and second generation basal insulins, glycemic efficacy is the same. That is, the ability to reduce A1C is the same between first and second generation, but marked difference being the PK/PD properties, which will say about your hypoglycemia risk. So the BEGIN is the entire group of trials which look at the comparison of glargine with the addition of the U300, and you have the addition which compared with the other second generation, and most of them have shown that it is actually the hypoglycemia risk which is reduced significantly with the use of second generation insulins. Some of the studies, when we looked at direct comparison between the two basal insulins available, this is a type 1 clamp in the type 1 diabetic patients, the clamp study, there are some data to suggest the glargine 300 has less variability than when compared with the degludec 100. So you have 20% lesser within the day variability than when compared with the degludec. And some of the data to suggest if you have shifted from first generation to second generation basal insulin, how things have changed. Predominantly the reduction in hypoglycemia. Onto your right, it is the A1C reduction. A1C reduction is almost the same, but there is marked difference. The left side peaks are the ones which showed that there is big difference in the hypoglycemia reduction. And another study which looked at in the type 2 diabetes, the CGM data, which again compared a time in range between glargine 300 versus degludec 100. The primary objective being how much of time the person spends with the time in range. And again, if you look at the time below range was markedly less with the usage of glargine 300 than when compared with the degludec. So anytime hypos, nocturnal hypos or severe hypos, there is definitely a big difference than when compared with the other second generation basal insulin analogs actually score over the first generation for the extraneous benefits of reducing the hypos, reducing the nocturnal hypos, and ease of administration. So in summary, first and foremost, prolonged duration of action, and actually these are the ones which have helped in actually giving you a true long-term single dose of injection, which unlike your first generation basal, we could not achieve. Higher dosages of glargine or detimer, we had to split the dose and give twice, but here you can give only once. And another advantage is somebody who is traveling maybe for short time or maybe able to miss one dose, your control is not going to suffer with this. So if you are using this, there is a prolonged duration of action. So one odd occasional missing dose, it is not a problem. And you can actually have the window of taking it even after 6 hours. So that makes it more easy for the patient to manage. Second important thing, the less volume of injection. So if you are looking at say 100 unit per ml and 300 unit per ml, obviously it's 1/3 of volume. More relevant for somebody who are requiring higher dosages. So you don't actually have any problem in injecting. The ease of administration is very much there, and there are less chances of nocturnal hypos. And because of the better actually action and better hypoglycemia profile, there is no defensive snacking with the usage of this, and that will actually translate it into a benefit of less weight gain with these patients. Real world evidence and RCTs have shown robust evidence with the usage of generation second basal insulin, and glargine 300 in direct comparison studies with the degludec has shown better time in range and variability with reduction in hypoglycemia. So this was the basic difference between the first generation, second generation basal insulins and some direct comparison. How many have you seen this movie? Okay. So if you are looking at the generation 2, it is bolder, bigger, better than when compared with the original. That's what is actually the second generation. I have finished here.
Thank you, Dr. Harikumar, and very illustrative and evidence-based talk.